Well, it's indeed an honor to be here and to talk about these issues, especially in front of someone who I learned about these issues from many, many years ago in an agency called HICFA, which some of us are still quite proud of. But today I wanted to talk a little bit about the fact that people with serious illness, of course, face multiple challenges in addition to their illness, from family caregiving burdens, financial consequences, and our fragmented healthcare system, and what strategies can help moderate these impacts and improve access to care. So this is a forward-looking, uplifting. We're not talking about going backward and reducing our programs. I'm going to talk today about ways we can improve and expand them, especially the public programs. And I do have slides, so.
There's the green arrow.
The green arrow, okay. So what I wanted to talk about today were really three topics. They told us we should do three things. First, how we make Medicaid more available, how we make Medicare more affordable, and finally, how we begin to address disparities for vulnerable populations, the low-income minorities, and the medically underserved. And I think that we, as I always do, because it's the core of what I've worked on, making Medicaid more available is the first topic I'd like to cover. And I really think that the strategy on Medicaid ought to be that we increase access to home and community-based services and complete the rebalancing of institutional care to home and community-based services. I think we need to really begin to deal with, in the days of talking about more flexibility for states, the impact of some of the variations across states and the fact that when so much is done through waivers, we have very uneven coverage around the country. And I think we need to facilitate the integration of services so that we don't have the kind of fragmentation that especially people with multiple healthcare needs face. And we need to finally close the coverage gap for low-income adults. Now, that gets me into traditional Medicaid expansion debates and the fact that we leave 2.5 million adults below the poverty level without any access to coverage through either Medicaid or the Affordable Care Act. Now, I think when we talk about Medicaid, some of the key areas that would support access and equity for people with serious illness are to expand and improve on home and community-based services eligibility. And I'm happy to say that finally the Senate has just passed and agreed with the House to send to the President an extension of the authority for the spousal impoverishment provisions to be in place for home and community-based services. They had expired, and I understand that's on its way to the President for signature. Let's hope he doesn't veto it. But that is an example. That provision is only in place until the 30th of September and then would have to be renewed again. So we need to begin to look at ways to make that kind of support more permanent. We also need to work on ways to help shore up the direct care workforce, because with many of the workers that go into these homes, their wages and their income makes them impoverished as well. Many of the states are now looking at how to provide more housing supports to keep people in the community, and we have a dearth of real quality measures to look at really what's going on with the provision of those services. And just to highlight the fact that we do not have uniform coverage for home and community-based services, in 2017, 4.6 million seniors and people with disabilities used Medicaid home and community-based services at an expenditure of $82 billion. But 86% of the enrollment and 93% of the spending was at state options. So depending on where you live determines what you get in terms of services and what waivers are available. The only thing available in all states is the mandatory home health care services benefit of Medicaid. This leads, of course, to waiting lists and to individuals who have been on waiting lists for 2, 3, and 4 years in some of the states to get coverage. The second thing, of course, is that there's a lot of variation, too, in who's eligible. The only people totally eligible in all states are those who are SSI beneficiaries or people who come in through the Medicare savings programs, but the states have a great deal of flexibility in terms of who else to cover and how to cover them. Most have done well with children with significant disabilities, but not so well with other individuals. And as a result, we still have a great deal of variation across the country in the share of Medicaid spending that goes to home and community-based services versus institutional care. It's been being rebalanced, but it really is an incentive that needs to be further expanded because many of these states still rely very heavily on just the mandatory nursing home benefit. So the question is, what can we do to improve services? One of the issues is that long-term care has now been developed into long-term services and supports as a part of a managed care process in about half of the states that use capitation for the services. But we need to really think through whether we're really getting what the states think they are getting from having this capitation work. There's a lot of complexity to implementing it, and I think there you see that some of their incentives are to integrate physician and other services to try and improve the way in which care is delivered, but there's a lack of housing, a lot of other social determinants of health that cannot be addressed. So as we think through what we really want in the form of integrated services for the Medicaid population that needs long-term services and supports, how can we build that together? And finally, since you're concerned about disparities, to remind you that the 2.5 million people in the coverage gap, those are individuals below poverty in the 14 non-expansion states, are really highly reflective of some of the challenges to getting broader coverage for the low-income minority population, many of whom are at risk if seriously ill. And the income levels, just to demonstrate, I always like to show Texas. The income eligibility levels today for Medicaid in many of those states only cover parents, not adults without dependent children. And if you want to qualify for coverage in Texas, you can't earn $4,000 a year. So Medicaid has some challenges to broaden, to improve, and to fill in the gaps. But there are also challenges within Medicare. Capping the catastrophic coverage for Part D would be one improvement, broadening supplemental coverage through Medicare, that should say, and Medicaid's role in helping Medicare, providing options for high-cost, high-need populations, and filling some benefit gaps. And my Medicare favorite diagram is, this is kind of what we have if you're an elderly person, try and figure out how your Part D benefit really does work. But I want you to focus on that 5% at the very top, because the way in which the Medicare Part D drug benefit works is that when you reach the catastrophic cap, you still then have to continue to pay 5% of the cost of the drugs going forward, which leaves some 1 million people out of the 3.6 million that exceed the catastrophic cap with often very high catastrophic costs. Now, the subsidies that are provided to the lowest income do help. You see 2.8 million there who get their coverage with subsidies. So one of the options is to broaden who gets subsidies, but the more affordable option for beneficiaries would be to actually make it a hard cap. And we have recommended that, and I'll plug another study in the National Academies Affordable Drug Panel recommendation, on which I served, was to put in a hard catastrophic cap in the Part D program. And you see the need for that if you want to look. It's kind of hard to read them. I know I was supposed to have big font, but you can't put all those drugs on with big font. But you might take a look at this. These are the drugs that people exceed the catastrophic cap on. And at the top end, you'll see many of them are the cancer drugs. So that I think in looking at this as a committee, you might want to take a particular look at which populations are really hit most severely by the lack of a cap. This is the average out-of-pocket spend, the median spending for people who exceed it. And then, as I mentioned earlier, you also have another 19% of the Medicare population that doesn't have Medigap or any fill-in for their Medicare traditional cost sharing. And so I think in that case, you want to really look at, are there ways to either broaden the Medicaid coverage for low-income people, maybe raise the asset test so that more people with low incomes but some assets could qualify, try and figure out how to provide better protection for basic services. But the other area that I think one needs to focus on is what happens to people in Medicare Advantage plans if they are seriously ill and they want to get out of the network in their Medicare Advantage plan. And we have been looking at the fact that in many states, if you want to get out of the Medicare Advantage plan and go back into traditional Medicare, you have pre-existing conditions that prohibit you from being able to access Medigap coverage. So that then a lot of people get locked into their Advantage plan, which may help them with their cost sharing, but may not give them access to the kind of specialty care that they want. So we have been looking at and talking to some of the states about the fact that 4 states currently make access to the Medigap market available on a continuous basis, but others do not. And this may be an area to really look at, trying to improve coverage and choice for people. So finally, if you're thinking about improving and addressing the benefit gaps in Medicare, some of them include other things like dental and eyeglasses, but really the one that needs the most help is probably the long-term services and supports area. And you could obviously expand Medicaid, but in the long-term way, if you want everyone to have access to those services, Medicare is the broader vehicle. And there's also in the traditional Medicare program no annual out-of-pocket limit for medical services. There are those limits in the Advantage plans, but not in traditional Medicare. So Andy will probably be able to talk about that better as the most recent administrator, but I think there are a lot of changes in the Medicare program where many people with serious illness are that could help make it a more affordable program for people and also provide some broader coverage. And then finally, since I was told that one of the issues you cared about was addressing disparities for vulnerable populations, I can only say that through all the work we do at Kaiser, the people who are the most in need of help and assistance are often the people with the fewest resources and the lowest incomes, and many of them are disproportionately from the minority community, as well as individuals who live in medically underserved areas. And so trying to look at, and it's not an issue we work on a great deal at Kaiser, but trying to figure out how to improve the workforce for these services, to try and improve the support we give to caregivers, the training we give to families, and a recognition. There was just a great article in the New York Times recently about someone who had cancer and was getting the treatment for cancer, but the economic cost to their family of having to stop working in order to try and take this person to their appointments, for this person to have to stop working while they were getting treatment, for the cost of bringing caregivers or family in. And so I think when we look at the economic costs of serious illness, we need to broaden it to look at how much support does that take, in addition to just looking at it through the lens of what the healthcare programs cover and what they don't. And I think when we think about looking at disparities, we really want to look at how to provide services that are bringing people to health equity as opposed to necessarily health equality. And I really want to end with this definition that comes from the Centers for Disease Control. Health equity is when all people have the opportunity to obtain their full health potential, and no one is disadvantaged from achieving this potential because of social circumstances, which really brings us back to looking at some of the social determinants of health, how to overcome some of those barriers, and to achieve equity. We really need to be looking at how to balance that out. It's not whether everyone sees the doctor at the same amount of time, it's whether people have the same opportunity. And I know that's really part of what you all are working on, and I think this group is really making great contributions to helping to lay that out so that those of us in the policy world can have a little bit better guidepost of where to go. So thank you very much.